For the first one, this is obviously for shock. So what are standard signs and symptoms when somebody has low blood volume? So what type of shock is this referring to? Hypovolemic shock. So what are standard signs and symptoms? How do you recall that? What do you think of whenever you think of dehydration, hypovolemia? Because what will always be automatically stimulated? That's how our body responds. You're not drinking enough, or you're bleeding to death, or you're having diarrhea. So what sympathetic? So what are sympathetic manifestations? Low blood pressure. Okay, so very good. And what else? What happens to urine output? What happens to your skin? What will the patient feel? Or sense of impending doom or anxiety, right? So that's all brought about by the sympathetic hormones. Okay. And what are your actions? What do? You see them in every patient. So what do you do for those patients? Okay, so if you don't have any, the patient can't take anything by mouth, then obtain orders for IV. Okay. And you monitor what? How do you know you're giving enough or not enough or too much fluids? Okay, what else? Okay, so look at the same manifestations you saw before you gave the fluids. Okay, so that would be your basis. Your objective is to correct all those, correct? So let's say BUN creatinine, what do you expect it to do after you gave fluids? To decrease. Okay, so you're trying to eliminate the initial manifestations. Okay. Did you have something today? Everybody's dressed up? Well, most.
We have management finals.
Okay. I thought you had a mock interview or something. Did you have your mock interview today?
No.
Where are you going, Diallo?
You're making us all.
You had a wedding yesterday.
So you never went home? Oh, the after party, right? It's too late to go home at 5 a.m. So, all right, risk factors for each type of shock. So we have 4 categories of shock: hypovolemic, cardiogenic, obstructive, and neurogenic shock. So risk factors for each. Name some. So risk factors for hypovolemic shock. Okay, anything that will cause the patient to either lose blood and or fluids. What about for cardiogenic shock? Okay, number 1 example is an MI. What else? What about dysrhythmias? Okay, dysrhythmias. Correct. Where would you put pericarditis or cardiac tamponade? Where will you put that? Cardiogenic or obstructive? Where are you? Why'd you say cardiogenic? Okay.
I caught myself.
All right. So please keep in mind, cardiogenic is direct pump failure. The heart itself failed. It could be an electrical conduction problem, could be a heart attack, a vascular conduction, electrical conduction problem, or a structural problem inside the heart. It's referring to valves not opening or closing completely. So those are all your direct pump failure causes leading to cardiogenic shock. Everything else happening around the heart, pulmonary problems like what, for example? Pneumothorax, tension pneumothorax, what else? PE, okay, especially a massive PE, chest trauma, other types of chest trauma, or pericarditis leading to cardiac tamponade. Those are all extra, right? Those are all indirect pump failure. And then finally, neurogenic shock. What's the top cause? Because there are 3 types of neurogenic shock. We have anaphylactic, septic, and yeah, they're all distributed shock. So we got septic, anaphylactic, and neurogenic shock. Okay, so for neurogenic, top cause is Spinal cord injury. Okay, it's always spinal cord injury. And then what else? For anaphylactic, of course, hypersensitivity, drugs or foods or chemicals. And then what about for septic? So, right. So keep in mind, it's also caused by acute lung injury. Okay. So sepsis tops the list, or any other conditions that increases your risk of sepsis. So the manifestations will be the same. There are 4 stages of shock, except in septic shock. Septic shock has a different stage, correct? So for what are the, well, we focused on 3 because the initial we disregarded. So what are the 3 stages of shock? Compensatory, or also called non-progressive, and then progressive, and then refractory. Okay. Make sure what are the differences between the 3 stages? How do you tell them apart? It's because they're all caused by, what's the name of the stage again? Compensatory. So therefore all caused by compensatory responses. So which are sympathetic again, right? So brings us back again to the same sympathetic signs and symptoms. Now include lactic acid now, right? In sepsis or in shock, not just in sepsis. So in shock, why is there lactate increase? Why do lactate levels? Why is it included now? Why do we assess lactic acid? Okay, because of the exposure of cells to anoxia now, okay, because there's not enough oxygen circulating. So the body continues to work without oxygen this time. So the consequence of that is always lactic acid buildup. And the higher, of course, from one stage to another, so the lactic acidosis causes the pH to do what? Drops the pH. Okay, so therefore from non-progressive or compensatory to progressive to refractory, differences is the severity of the acidosis. The pH will drop and drop and drop as you progress. What about the mean arterial pressure? What's the difference between the numbers? Remember, there's a table for this, comparing all 3 stages. Okay, so look at the each column, how severe it is. What happens to the potassium levels here? Goes. Why? Why does it go up? Okay, because as the lactic acid levels rise, the cells start dying. Okay, so that's killing cells. So where did this potassium come from? From the cells that were destroyed, from the dying cells. Not from, was the patient eating bananas during shock?
No.
Okay. Let's go to sepsis. What's the surviving sepsis bundle again? So in what order?
For the first.
What's your first action?
Draw blood.
Blood for what? That's correct. So draw blood for what? Culture and lactic levels. Okay, so that's always the first action. Followed by, what's hung next? Antibiotics, followed by fluids. Very good. So in that order, okay? Don't worry, how long is it between each action? Few seconds, okay? Just a few seconds. Of course, these are experienced nurses, okay? Drawing blood and then hanging. And is it usually just one nurse taking care of a septic shock patient? Okay, multiple, yes.
So question, you said obtain blood cultures comes before measuring lactate acid.
Well, it's the same blood sample. So you draw a blood sample, that's for culture and lactate levels. So there's 2 bottles for, yeah, so 2 bottles for your culture and then another bottle. So a gold top for your lactate level. By the way, lactate blood sample should always be in ice. So you put that in your biohazard Ziploc bag with ice. Okay.
So should I follow way how it says on chart 11-6?
Which
It
is
says measure lactate, then it says obtain blood cultures, then administer broad spectrum antibiotics, then begin rapid administration of fluids, then
and
administer vaccines.
yeah, vasopressors if needed. Again, the blood sample there, that's the same blood you're drawing. It's just it just depends on which bottle you what specimen container you put it into. Okay, but you're drawing the same blood. And it's not like you're sending the lactate first and then sending, oh, I'll send the lactate later. Okay, so it's all sent. But they have to, I mean, they have to write one or the other, first. Here, how do you go, let's say from neuro? Let's start with the neurological changes. What will you find for in shock? So there will be, as oxygen levels drop, always. Okay, either decrease LOC or changes, right, in mental status. Let's go now down to respiratory. So what happens to respiratory assessment? Respiratory rate will rise. Okay, as oxygen levels drop, respiratory rate automatically increases. And what happens to lung sounds? Because here the heart rate is increasing, correct? So therefore, what happens to cardiac output? Decreases. So what will happen to lung sounds now? Well, depends on which type of shock, actually. So for cardiogenic, we will hear. Specify. All right, because this is heart failure, right? So MI always leads to heart failure. So that's for for your pulmonary. And then for all other types of shock, they should be, lung sounds would be, okay, yeah, that'll be clear. GI, what will you find in your GI assessment? Okay, so little to no vowel sounds. So what will be manifestations of that? So how will you know there's little to no peristalsis? Patient will, well, constipation will be like days or, because you can't observe constipation right now, right? So what will you see? Something acute. What will be an acute GI manifestation when there's no peristalsis?
Distension.
Okay, so there'll be nausea, vomiting, and distension. Let's go now to urinary. Will the patient have urinary retention or oliguria? What's the difference between the two? What's urinary retention versus oliguria? Is it the same?
Oliguria is
Okay, so which one is it? So in shock, what will the patient show? Retention or oliguria? Oliguria, because urine output production decreases.
Wouldn't it reflect on the stage?
No, retention is, don't confuse urinary retention with fluid retention. It's not the same. Urinary retention means, do they have urine? They do. Is it coming out of the bladder? No, that's what it means. So let's say in dialysis patients, do they have urinary retention or oliguria?
What is it?
Oliguria, because the kidneys are not functioning. So that's for each stage and the rationale. So we're discussing now the rationale for the manifestations. Cardiogenic shock, the example I'll be using on the exam is the classic MI. So this will cover also acute coronary syndromes at the bottom of the blueprint. So what are the drugs we use for cardiogenic shock? Not for MI, okay? So for the shock itself. So because in chapter 11, it's discussing management of cardiogenic shock. In a different chapter for acute coronary syndromes, that's treatment for the MI. Okay, so there's two sets of medications. You treat the MI, plus you're also treating shock, okay, cardiogenic shock. So what are these drugs for cardiogenic shock? Okay, we're now using what else? So besides dopamine, vasopressor, and okay, so inotropic agents, right? So we're using the nitrates. Okay, so we're using those now to well, there have to be cardioselective nitrates to only dilate coronary or peripheral blood vessels. Coronary, okay, coronary blood vessels. Do they get fluids?
Of course, yes. Cautious.
Okay, very little fluids, okay? What about, yeah, you give oxygen. Do they get diuretics? Cardiogenic shock. Okay, very good. Okay, so some people have trouble grasping why are we giving diuretics to someone in heart attack when the blood pressure is low, correct? Yeah, wouldn't that make sense? I mean, why would you give a diuretic which drops blood pressure, drops blood volume in someone with cardiogenic shock? Why are we doing that? Why are we trying to kill the patient? Are we? No. Because what are you doing when you're giving diuretics to someone in cardiogenic shock? We're decreasing preload. So by decreasing preload, you improve cardiac output. Kind of ironic, right? But it makes sense because the heart is in acute failure. So therefore, can it handle normal blood volume? It can't. So you have to drop preload to increase cardiac output.
So that's why the patient is in ICU.
Okay, there you go. Hypovolemic shock. What's the mainstay treatment for hypovolemic shock? Fluid and or blood products plus, is that it? If unresponsive, but are we just doing that or are we treating the underlying cause as well?
Yes.
Okay, you have to treat the, let's say it's diarrhea, so you put a cork, right? What else? Do we use a cork?
No.
No. Okay, so you stop the diarrhea. So you treat, let's say it's diabetes insipidus. So what will be given to the patient as well? Desmopressin. Okay. So how do we know again that we're giving enough fluids? Because it's not, is it based on how many bags you give or are the patient's response? What are those responses? Okay, just urine output for the whole shift? Okay, so hourly, okay? So how do we accomplish hourly urine output? Because we can't wait until you clock out to evaluate. We have to evaluate every hour. So how do we know hourly urine output? We need a Foley for this. Okay, so this would be, is this a justified reason for inserting a Foley?
Yes.
Very justified. You see there are redundancies here. That just means there's multiple questions. So let's say at least one question on this and that. So similar topics, but multiple questions. So that's at least how many on shock? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 13. Is this one for complications? Okay, let's go now to, let's review quickly emergency management. So for anaphylactic shock, since these are emergencies, so what do we do with anaphylactic? Okay, first drug is epinephrine, followed by Benadryl, diphenhydramine, because what will epinephrine fix the anaphylaxis? No, what will epinephrine do? It's just going to cause, what does epinephrine do to the blood vessels? Vasoconstriction. So how does vasoconstriction cause bronchodilation? How does it do that?
There was inflammation.
Okay, so because remember anaphylactic shock, just like neurogenic and septic shock, do we have vasoconstriction here? In all three, we have vasodilation. So epinephrine is appropriate for anaphylactic shock. So it will constrict all your blood vessels. So instead of your airway muscles being dilated, they're now going to constrict. So therefore, what will happen to the wall? Thin out, increasing the airway, okay, airway size. And then, of course, the diphenhydramine will stop the self-destructive response by the body, because it's really our own body causing the manifestations, correct? It's our histamines, our cytokines causing the massive inflammation in anaphylaxis. And then after the two drugs, what's given? Albuterol. Can we give steroids?
Yes.
Okay, steroids. Okay. Steroids always last. In neurogenic shock, what's the first item we give? So by the way, all of these are given oxygen, right? So we assume you already gave oxygen. So what's the first drug for neurogenic? So let's say a patient has spinal cord injury and you see, what are the manifestations of neurogenic shock?
Bradycardia
Is the only one that has Brady, and hypotension, of course. So what will be given to the patient? This is still vasodilation, so you give no IV fluids first, saline or LR, and then followed by atropine. Okay, and then what's the third one? Vasopressors as well. And we already discussed cardiogenic shock. Okay. All right, so let's review consequences. So all of these shock patients, all four, can they develop complications? Okay, so these are now DIC and ARDS. Do they come during the earlier stages? Okay, this is toward the progressive, and it begins around progressive, right? So DIC, for instance, the clotting begins in the progressive stage. That's why the INR starts rising. And then followed by under refractory, that's when you see full-blown DIC and ARDS. That's it for shock. Any questions? All right, burns. So we had, was it a table or a chart for the first aid, the initial therapy? It's a table, okay. So focus on thermal and chemical burns. So let's say thermal, so what do you do? The patient's on fire or just had fire exposure. Okay, stop the burning and okay, put anything wet or damp. A wet towel, yes, or you guys have the table number?
Sorry. 57-1 is the degrees. So
Yeah.
It's not, that's not the first aid.
On the scene first.
That's just.
It's what.
Yeah.
Okay, on the scene,
So
57-3. Oh, well, no, this one is the faces. No,
57-1.
Oh, this is-
should be before, right?
It's 57-4.
Okay, I see it. Part 57.
So it's later.
Yeah.
Yes.
Okay, here, 57-4. What about for chemical? There are. Do we douse them with anything if it's chemical? Just make sure.
So
If
if
it's
it's
powder,
on the
wash
issue.
it.
Yeah, so the principle, if it's a dry chemical, don't wet it. Right, so for wet chemicals, just try to remove the clothing. Okay, so to prevent continued contact of the chemical with the skin. What do we mean by circumferential burns? Okay, so an entire body part. So let's say an entire arm, an entire leg, an entire torso. Why? It becomes a compartment, okay? Because the skin will become let's say this, okay, becomes a tourniquet, okay, causing compartment syndrome. So let's review the 6 P's again.
Paresthesias, paralysis.
Pressure,
Poikilothermia.
pulselessness, and poikilothermia. Oh, it's care. So besides recognizing, so you recognize the 6 P's. So what's your first action? You see the 6 P's. Yeah, you saw them. You saw pulselessness. So what do we do now? Clap your hands. Yeah. What? Okay, RRT. Is this a surgical emergency? Yes. How do we decide which patient to see first? Management of care. So what are those 5 methods we use again? Because there will be a few prioritization questions here. Maybe 3 or 4. ABC, you can ABC. What else? You can Maslow. Can you acute versus chronic? And you expected versus unexpected, and stable versus unstable. So you use that. So there's at least 2 here. 1, 2. With burn patients who have burns to the chest or clothing, upper clothing was burned, burns to the chest, to the neck, what's your priority? Or to the face? Okay, it's always airway. Do we intubate soon or later? Okay, so what are the phases of burn injury? Emergent, also called resuscitative, okay, phrase, followed by acute, okay, next is acute. And then rehab, okay, but rehab, we don't bother with that because that's years. So we'll focus on emergent or resuscitative and acute phases. What formula do we use? There are 2 here. Which one for adult? 4. Okay, so 4 ml. Okay, times the weight times the percentage of TBSA. Do we convert the percentage to a decimal? No, keep it a whole number. When do we count? How is the total fluid we calculate here given?
Half for the first.
Okay, half will be given over first 8. And when do we count the first 8? From the time of the burn. And what about the other half? 16 hours for the other half.
So, for example, what happen if patient come here at night, it's that 7, so
I mean, divided by 7.
7, yeah, so for the, you want to have still 60.
Yeah, because I mean, this patient won't be alive if we miss the whole 8, right? They're dead. Okay, they have to be kept alive to reach the next 16, right?
So it's maybe 60. Even though we use 7.
Yeah, everybody will have 16 hours, but not everybody will have 8 hours. Okay, this really the crucial. You understand?
It's from the time, wait, so from the time they get there or the time the burn is happening?
Which is the answer?
That happen.
From the time of the burn.
But by 7, by 8.
Depends. Depends on how long did they get to the hospital.
So you would ask like how it's like how does that?
Yeah, I mean, unless let's say the patient's burn injury was unwitnessed, right? Nobody saw. You understand? What's the yellow? What's your question? Right.
7 or 8 hours?
I can't answer that. What time did the patient get to the hospital? The example given by Sonia was the patient got burned at 8, got to the hospital at 9. So do you divide by 8 or 7? Divide by 7 because they lost 1 hour. So it depends on the time of the injury. You do a calculated guess. I mean, okay. Yeah, exactly. Take note, these formulas are only guidelines. So therefore, how do we know that our fluid replacement is accurate? Because there are two, let's say, let's give your example of, let's say, Diallo or Asia's question, wherein nobody saw what time the patient got burned. And then, what's the other variable here? The weight. Is the weight accurate? Because when the time, let's say the patient was already burned, is that weight accurate? No, because did the patient start edema already? Yes, the edema already set in. So remember that weight of the edema is not supposed to be included because is that water really in the cell or in the blood vessel? Neither. So therefore, the weight is not accurate here. So this is one exception in the weight being the basis for fluid status. Everything else in dialysis and heart failure patients, the weight is most accurate, not in burns. It is the only exception. So therefore, how do we know? We did our very good calculation. We're very masters of math calculation. So how do we know it's really enough? Okay, so we base it on a urine output of how much?
1.5.
Okay, half to 1 ml per kilogram per hour. And here are the other details also for chemical burns. This should have been also mentioned already in the chart 57-4. What's the purpose of removing clothing and jewelry? Okay, plus they will become constrictive materials. This will also include the ID bands. Okay, so sometimes we put the ID bands too snug and then not anticipating the edema, and then the ID bands start digging into the patient's skin. So this is now a device-related injury, right? So we caused the injury already. Or just change the ID band as you know, as the edema worsens, just cut them off, put new ones on. Where were we? Each phase. Okay, not we only discussed the emergent. So what is our focus on the acute phase? Okay, wound care and infection prevention. Now, how do we know the patient is now in the acute phase? Is it based on the time?
So not only.
So what's the basis? How do we know the patient has left the resuscitative phase?
Diuresis.
The urine output increase. Very good. So as the patient's urine output is now too much, it went from oliguria, anuria to now diuresis. So now we know they made it. They made it into the acute phase. So do we do the massive fluid? No more. So now we focus on infection prevention and nutrition as well. We just discussed the Parkland. And that's it. That's most crucial for burn patients. The rest would be, because the rest of your care, will burn patients be just a few days in the hospital? No, it'll be months to some years. And then not to mention these serial surgeries, the cosmetic surgeries they will have to undergo.
Professor Scott, are you not gonna say like contracture, do you know when birth starts healing, you said your skin kind of gets
no, but for the NCLEX, what's your principle? What do you follow for positioning, for instance? So you mentioned contractures. So how do we prevent skin contractures? In extension or flexion? Extension. Okay, always extension. So let's say Shalea's burn injury is in the back of her neck. How would you position her in bed?
Chin down.
How? Olu is keep doing this. The burn injury is right here. Okay? Yeah. Okay, so it will be like this. Because is that extending the body part? Yes, it's extending the burn injury. You follow? What if it's my elbow that was burned? How will I keep it flexed? Very good. Okay, so the point here is what again? What are you trying to the burn injury? Stretching it. You're putting it in an extension. Okay, I'm not saying extension of the joint, extension of the body part. Okay, the skin, because this is skin contracture. You want that to heal, you have to stretch it. So really, I can't say one answer. It will be depending on what body part was burned. So of course you extend or you stretch the burn skin so that it heals nicely. You don't get any contractures because it will scar regardless. Of course you'll have a pretty bad scar, but we don't want that scar contracting. Okay, we don't want the skin to contract. Last one, the knee was burned. The kneecap was burned.
bended.
Very good.
What if it's your butt?
Okay, so for a body part that has no joint, that's not joint, it will be garments. Okay, so we will put.
Or would you lay on it?
Well, eventually they will gonna have to, but for long periods of time, avoid. Okay, but it will be compression garments. So let's say the whole body, we don't have joints in every few centimeters, right? So they will have to be wearing a full body garment. One of those, yeah, so you only have openings here, mouth, nose, and eyes. Yeah, compression garments. Okay, they have full body suits for those.
They have like the little holes, like they look like a mesh.
No, just the only open is the mouth, nose, and the eyes.
Like cosmetic surgery, right?
Yeah, eventually, yeah. But it'll be this one I mean by in the rehab. So the most important parts is the emergent and the acute. After that, it's wound care for years. Yeah. Well, depending on how much of the body was burned, depending on the TBSA.
When they were like trapped up when they came and everything, and they were just like once it was flat now.
Yeah. So let's say it's a jacuzzi, right? So jacuzzi would be just your lower half of your body. Then you're fine here.
For the coffee and they had a whole body.
Okay, let's go to immunity. So for transplant, there are only 2 questions here. No, sorry, 2 items, but it could be more than 2 questions. What are the 3 types of rejection? I mean acute. Oh, hyperacute. Hyperacute, acute, and chronic rejection. What's the difference between the 3? Okay, the one is the onset. So when does it happen? When does hyperacute happen? Immediately within 24 hours. That's hyperacute. What's it caused by? That's acute. Clotting. Okay, so hyperacute is caused by massive clotting. Okay, and then the what's the treatment for hyperacute? Nothing. Okay, remove the organ. It's dead. It's gone. Let's go to acute. When does it happen?
Like 48 hours.
2. Is it only up to 2 weeks?
No, I didn't say 2 weeks, I said weeks.
So when will acute rejection happen?
Over weeks to like a month.
So after a month, I'm okay. I'm never gonna get acute rejection. So after 6 months, I'm good.
You're technically.
So forever.
Okay, forever. Remember, the description in the textbook is anytime after 48 hours up until the and sporadically, right?
Yeah.
It'll last until while the patient's alive, or as long as that graft stays in the patient will continue to be at risk for acute rejection. Is it a one-time episode?
No.
There will be repeated acute rejection episodes. What's the treatment for each episode? Okay, because what's it caused by? Why is the treatment increased doses or increased number of? Okay, it's caused by the cytotoxic activity by the lymphocytes. Okay, so it's the body attacking it. Okay. Chronic rejection. When does it occur?
Over like months to.
Okay, months to years. What's it caused by? Chronic inflammation and scarring. What's the treatment? So is there a treatment for it?
There's no treatment.
No, really. Okay, so right, we can delay it, right? That's all we can do. Conservative treatment, okay, or symptomatic treatment. So this one specific to the kidney. So this was on was it a table? The question is only on kidney rejection.
There's not a table for that, it's only a paragraph. It's on page 1597. There was something for the medical management.
Talking about the medication or?
There's a chart that says something in the beginning, chart 48-14. Talks about kidney transplant rejection infection.
Page 1599. Yeah.
Why are these patients at risk for infection?
Because
What else are they at risk for since they're taking these forever? They're Cushing's as well? Okay, Cushing's disease or syndrome? Disease or syndrome? What's the difference between Cushing's disease and Cushing's syndrome? Not autoimmune. Syndrome is caused by? Because in Cushing's syndrome or Cushing's disease, do they look different?
No.
Exactly the same. But since the causes are different, will the treatment be the same? So that's what I'm asking. So Cushing's disease, what's causing it? Will these patients with, after a transplant, not just kidney, any transplant, will they develop Cushing's disease or Cushing's syndrome?
Syndrome.
Why syndrome?
Because
So therefore, where is the steroid coming from? Sure. Where did the steroids come from in Cushing's disease, Cushing's syndrome? Patient took it. Patient's taking it. That's what's causing the Cushing's syndrome. In Cushing's disease, where did the steroids come from? From the body, caused usually by a... Why do they have high steroids in Cushing's disease? We know in Cushing's syndrome, they're taking it. That's why the steroids are high. But in Cushing's disease, why did the patient have high steroid levels? So I'm stressed. I have Cushing's disease now. Really stressed out. Today's tax day. I haven't filed my taxes yet.
It's a high ABPH.
All of them will have high steroid levels. But yeah, you're warm. Okay, you're so high. So why? So why did the... No, you're there. So why did the ACTH rise? Because what's causing it? What is that core? What is that something wrong? An adenoma, right? There's a tumor. So either a pituitary adenoma or a adrenal adenoma. So it's a tumor. So how do we treat Cushing's disease? Surgery, surgical removal of the tumor. So wherever that tumor is, in the pituitary or in the adrenal gland. It's in the exam, right? There's no Cushing's in the final exam?
After Friday, you used to have Cushing's everywhere.
Are you sure?
This is giving me anxiety. My cortisol levels are high.
Is that Cushing's disease or syndrome? No. Neither. It's not gonna cause Cushing's. Yeah, you're right. Okay, never mind.
So disregard will be declared.
Still taking the endless.
Disregard for right now, is what I meant.
Okay, so therefore, side effects of immunosuppression. So we got the Cushing's and Cushing's disease or syndrome. And then what else? Infection. Okay. So therefore, will your teaching be any different from those you taught patients with cancer? With neutropenia? No. Okay, so same teaching. So can they clean up pet litter?
No.
Nobody else can do it.
You said they should be.
Okay, so you can use PPE, yeah? So masks, gloves, yeah, you can clean up if you have to, okay? Make sure you wash your hands. So should they go parties, to parties?
No.
What if they wear PPE? No, they won't. They're being, yeah. People will understand. Yeah, try going to a bar. That is if you can get in wearing that ridiculous thing. All right, let's go to cancer. So what are treatment issues in chemo? Okay, let's start with the, yeah. So what do we call that period again? Wherein they're at most risk. So between, okay, nadir, okay, nadir. So it's usually 2 weeks, okay, one week to 10 days for most chemo agents. Okay, so each drug will have a different nadir. So that's number one concern. So during nadir, what will the patient develop? Anemia. Okay, all right. So between the three, which one is most crucial? Neutropenia. Okay, neutropenia is the most crucial. Okay, the anemia, thrombocytopenia may kill the patient, but not as fast as neutropenia. Okay, remember they go septic. Okay, that can cause sepsis. Once they have an infection, can't fight it, sepsis, then you go septic shock. The body is pretty resilient with anemia. Okay, we can last weeks or months, okay, with anemia. So treatment side effects. So what are the 3 treatments we discussed in class? Surgery first. So surgery, and then followed by chemo, and then radiation. Okay, so this is referring to side effects for each. So what are side effects of surgery? Correct? Okay, also. And then depending really on the site that was removed, right? So what body part was removed? That would be your side effect. So let's say, can we remove the head? No. So only non-vital organs can be removed. Okay. So let's say I lost my larynx. What will I have now? I have no larynx. I'll have a tracheostomy. I have no esophagus. Peg tube. Okay. I have no uterus.
You can survive.
You can live.
I don't have one anyway. I never had one. Okay. I have no testicles.
You can have babies. But you could go to the positive before the I think.
Correct. Okay, so I can bank first before the surgery. So that for surgery. Okay, let's go to chemo. What are the 4 major issues we discussed in class for chemo? So Bone marrow suppression. So bone marrow suppression will lead to the three again: anemia, thrombocytopenia, and neutropenia. And then what's the second one? GI will be what? What's our concern for GI? Nausea, vomiting. The nausea is pretty severe. What else? Fatigue, which can be related to anemia. So what else? Still in the GI. The mucositis. Okay, so those large mouth ulcers. And then finally,
Hair loss.
alopecia. Okay. So
The cancer is somewhere in the.
no, it's really a side effect of chemo. So we concluded surgery, now we're on chemo. So regardless of the cancer site, you're receiving chemo, you will have all four: alopecia, mucositis, nausea, and the bone marrow suppression. There are many others, but we only focused on those four, correct, in class. So review management for each, because it's this saying management for the side effects. So management for alopecia, management for nausea, which includes mostly medication. So make sure you know the side effects of your antiemetics. Then of course, management again for anemia, thrombocytopenia, and neutropenia. What are those three colony stimulating factors we expect to administer? Filgrastim. Another one is pegfilgrastim. Filgrastim is Neupogen. Pegfilgrastim is Neulasta. Okay, just differences in the, but they're the same same purpose. Tumor TNM, tumor staging. You're good with this, right? You're comfortable? I had a high percentage for this question. So same question you had in exam 2 for TNM. No, was it exam 3? Cancer was 2.
The same exact question, word verbatim.
Different numbers. How do we explain? Because this is teaching a patient about metastasis. How do you explain metastasis to the patient?
So basically, metastasis, you have, if it's like one is basically one is within, it doesn't grow beyond.
No, metastasis.
So track repeat is when it spreads to another location.
So I have multiple cancers now?
No, basically
one
like
cancer but has spread to a different organ.
Yeah, basically.
Cancer became one spot.
And then,
so like, for example, throat cancer.
All right, let's go to benign versus malignant. So you were describing earlier about one being right in situ, encapsulated versus none. What about the size of the nucleus? Okay, normal and benign, and malignant will be larger, right? Larger ratio. Okay, so nucleus to cytoplasm ratio is larger. Which one is resembling normal cells?
Benign.
Which one is tightly adhered? Tightly adhered. Tightly adhered. Benign. Which one is poorly differentiated? Malignant. What does differentiation mean?
It's like this body cell.
Resemble to the original cells.
Radiation. Side effects will be based on the location, right? So it's because in radiation, are the side effects systemic or local? Local. Mostly local. Let's say I have radiation to the abdomen. What complications could I have? So what effects? So acute versus late effects. So what could I have years or months after the radiation to my abdomen? Let's do female. That way we cover, yeah. Could they have what? Correct. Yeah, they could develop a different type of cancer. What else? Okay, for infertility. What else? What else is in my belly?
GI upset.
Okay, I could have some GI problems. Could I have adhesions probably? Could I have constipation and or diarrhea? Or could I have ulcers? Could I have inflammation, let's say colitis? Okay, could I have, or yeah, so it can go either diarrhea, constipation. Could I have a bladder problem? Okay. Spinal problem? Yes. Kidneys? Yeah. Okay. Depending on the body region. What's the difference between sealed and unsealed radiation? Because brachytherapy, there are two types of brachytherapy. Sealed or unsealed. Okay. The chapters, this is based on the other edition. Where do you find, what's the difference between the two? Okay, so let's start with sealed. So sealed radiation
It's basically.
is the sealed radiation dose higher or lower? Higher, that's why it's sealed. So therefore, how much time can I spend with the patient?
30 minutes.
How far do I stay? Very good. So 6 feet, further and shorter time. What about unsealed? The dose is lower, so I can spend more time and I can stay closer. So 1 hour, 3 feet. The sealed, 30 minutes, 6 feet. That's under the hyperthyroidism chapter. So skincare, because dermatitis is common in radiation, is external radiation. So how do you care for the skin? Do I put some Neutrogena and some hyaluronic acid?
Like, can I use like? No salt, no powder. Could you put like?
Mild, okay, mild products. You can put let's say, yeah, Cetaphil, things like that. Or best would be something prescribed, okay, by the radiation oncologist. Do I expose it to the sun?
No.
Do I put sunblock when I am out in the sun? For how long do I do that?
Forever. You have to reapply it every. Reapply every 2 hours.
Okay, it'd be nice if you put it forever, but what's the minimum at least? You put it until a minimum of how long?
What you mean, like for the day or like in general?
Yeah, in general. Let's say I completed radiation today. This is my last day. At least 1 year, okay? At least 1 year, or like Ashley said, yeah, you can put it on. That's a nice, healthy practice, okay? Using sunblock. Precautions, because this is now about precautions. Which one of these two require body fluid precautions? Unseal. Okay, what types of body fluids are we referring to? Not really sweat. Sweat's okay. Yeah, blood. What else? Yeah, feces. It's like you touch it anyway, right? But what about reproductive secretions as well? Okay, so all fluids here are radioactive. Here, another same 5 principles. Oncologic emergencies, we have 6. So first 2 are DIC and DIC and sepsis. What's the other 4? Tumor lysis syndrome. Yeah, tumor lysis syndrome. Superior vena cava syndrome. Hyperkalemia and spinal cord compression. So that's 6. Questions on that would be, it's recognizing and managing. So signs and symptoms, how do you know that that's occurring? Because they're emergencies, so do we need to know how to handle what the nursing actions are? Yes. DIC, sepsis, and then SVC syndrome, hypercalcemia. No, not hypercalcemia, calcemia. Yeah. Hypercalcemia. Hyper. Yeah. TLS. Yeah. The tumor lysis syndrome is the one that has hyperkalemia in it. Yeah. So yes, technically hyperkalemia, but that's under tumor lysis syndrome. What's the other problem in tumor lysis syndrome besides hyperkalemia? Hyperuricemia as well. So gout, you managed gout last semester, so you should know. And since it's managing as well, so do we need to know management for each of those? Okay, including hyperkalemia management. So how do we treat hyperkalemia? I've been jamming this since last semester. So how do we? With dextrose.
And then you have the calcium.
Very good, children. Let's wrap up cancer and then we'll take a break. Risk factors for cancer. So we had chemical, food, viruses, lifestyle, radiation as the most common risk factors. Primary versus secondary prevention. For secondary prevention, use American Cancer Society. This is American Cancer Society, okay? This is not acute coronary syndrome. That's, you still know how to get to that website?
Yeah.
Okay, cancer.org. Bone marrow biopsy procedure. So teaching, we have, remember again, there's 2 patients here, the donor and the recipient. Where do you position the patient after the donor? How do you position the donor after the procedure?
On their side.
On the harvest side. Okay, that will help with the pressure, applying pressure on the harvest site. Which is the most common harvest site?
The left side.
The. So yeah, which bone is that? Iliac crest. So I guess there's 2 questions there because there's 2 lines. And this one, there's multiple because there's one here and then there's one under anemia right here under gas exchange. How do we, what teachings do we provide? Well, during treatment, no, right? Yeah, because for which radiation again? Unsealed. Okay. What about for sealed? Can they still have sex?
No.
Yes, if it's under 30 minutes, I mean, under an hour.
No, they cannot. Wait, repeat that again. I mean, they
Wait,
cannot.
I don't know if it's right. Yeah.
Can you do sexual intercourse from 3 feet away or 6 feet away? Oh, wait a minute. No. This is we're referring to if it's, of course, no sexual intercourse, but they can. But anyway, the question will be about, regular, sexual activity. So can they with radiation?
No.
No, neither for sealed or unsealed. Even if they wear a condom, still not possible, right? Because because of the distance. All right, let's take a break.